Welcome to Conversations with Melissa, part of RenaFi's Experts and Influencer series. RenaFi provides practical, research-based advice, courses, and peer support, and focuses on the underlying drivers of our ADHD behavior. Through courses like budgeting for the ADHDer, home organizing for the ADHD lifestyle, and of course, our ADHD book club, to name just a few, we provide a holistic program that serves to help you thrive with ADHD, not in spite of it. Follow our YouTube channel for ADHD resources and information, and visit us at renafi.com to learn what we have to offer. Thank you so much to our guests here, Dr. Bill Dodson and Beth Bardeen. So today we're going to do RSD from two perspectives. We have Dr. William Dodson, the clinician, what RSD looks like from the outside in. Dr. Dodson is a board-certified adult psychiatrist who does not have ADHD. He has worked with his adult ADHD patients for the last 25 years to understand and document rejection sensitivity dysphoria. Dr. Dodson has been on the forefront of diagnostic and treatment reform for ADHD and rejection sensitivity dysphoria. He is now retired from clinical practice and resides in Colorado. Beth Bardeen, the RSD survivor, what RSD feels like from the inside out. Beth is an adult diagnosed with ADHD after a 30-year career in the Seattle tech industry, specializing in marketing and organizational behavior. Now Beth researches rejection sensitivity dysphoria and is an advocate for the newly diagnosed, with a focus on explaining the internal experience of RSD. She lives in Seattle and is the founder of the Seattle chapter of CHAD. All right, thank you both for being here. And
Melissa, thank you.
I'm just going to step out of the way. I'm going to take the focus off me and let you have at it and interrupt you every so often.
Sure. And thank you, Rick and RenaFi too. This is, we love this opportunity, really appreciate it.
Okay, so this is the last medication slide. The actual robust response rate to an alpha agonist is disappointingly low. And if you, your doctor chose whichever one he was feeling lucky with that day and tried it, 30% of people would have life-changing level of benefits. And that also means that the other 70% of people usually see nothing at all or some mild side effects. If that happens, you just stop a medication that didn't work. I don't know why that has to be such a big deal, but stop a medication that's not working and then try the other medication, and you will have, again, about a 30% robust, life-changing level of response. So when you add them all together, the response rate is about 60%, which is about the same as for any other medication in medicine. You're going to get about a 60% good response rate. But many times people, half of people who get a response have to try 2 different medications at different times. You don't take them together.
We usually get questions on this slide.
Yes. Well, that's the question I usually get. Do you take both of them?
Yeah, both of them.
That doesn't work.
There are questions about medications. I'm going to do my best here. All right. So can clonidine, if I'm saying it right, can be taken as needed, or does it have to titrate?
And it takes 5 days. 5 days for the effects to be fully developed. If you're looking for it to be a mild sedative for your hyperactive child, settle down and go to sleep at night, yes, if you give them 1/10 of a milligram at night, it will help them go to sleep. But you're using a side effect there. It's not the intent of the medication. It's not its major purpose. It's just a very convenient side effect. and then it will work immediately. But for rejection sensitivity, it's a 2-week process to get the dose up. The dose that usually works the best. That's why I keep on saying the treatment of rejection sensitivity dysphoria is prevention.
Yeah.
You can't,
I
once
keep
you have
relating
the
it to an
episode,
allergy reaction. You wouldn't only take your daily allergy pills after the effect. They're there to help you from being allergic to things when
yeah,
they
and there's
show
no EpiPen here. There's no EpiPen to pull you out.
up.
No EpiPen. All right. So I'm hearing you say things about this medication and then in very small doses. So there's a question around cutting the pill. Like, hey, I got this. The doctor gave it to me. I felt jittery. Could I just decide I'm going to take less? Could I take half? Could I cut the pill?
Talk. Don't
Please repeat.
talk to your doctor. Don't mess with the medications without talking to your doctor and talking it through first. If you want to get a good way of being discharged by a physician, monkey with ADHD medications on your own.
Yeah.
Physicians don't like it.
Dr. Dodson, when you were active in practice and you had a new patient that you were going through an alpha agonist trial, how did they communicate with you? Was it by email? Was it by phone call? Did they wait for in between visits?
I'm kind of a wild man. Every one of my patients had my phone number and my email.
Wow.
Wow.
That's so
Very,
cool.
very rarely did anybody actually use the phone. Never had anybody use it
Because we have ADHD.
excessively, shall we say.
We have phone phobias.
Again, I'm the type of doc, if something's going wrong, I want to hear about it right now.
So that's a good
with
question
ADHD
for people to
medications,
ask their specialists is, how do I communicate with you in between our visits if I'm having jitters or if my pill's sedating me too much or the side effects just aren't right, then it's fair to ask the doctor how they can be contacted.
yes. Now, if they say no, you need to find another doctor who's willing to participate. At times it might be just a bit inconvenient.
Yeah.
Well, I love that you made yourself so accessible. We've got this is a room of very creative people. Let's say it that way. Stimulants often make me tired. I read that can be normal. I think this person's looking for, is that true?
It's called the paradoxical reaction. When you give a stimulant to a person with ADHD, it slows them down. And if the dose is too high, it'll put them right to sleep.
If the dose is too what?
High.
Too high.
Yes. If you're having side effects, the dose is too high. Period. End of sentence. Below your optimal dose, all you should notice is good things happening and no side effect other than young kids who are already rail thin, picky eaters will lose their appetite. But other than that, you notice nothing but improvements. If you're having side effects, the dose is too high, or sometimes you're on the wrong medication. So if you're on amphetamine, you should try methylphenidate. These are very gentle medications. The problem is that people have the notion that more is always better. And they actually induce side effects so that they can know that they're on a medication. It's not the medication's fault. It's that people have wacky thinking. Follow the instructions.
Ain't that the truth? People have wacky thinking. Speaking of that, I told you I had a couple of off the beaten path questions. Does RSD respond to psychotropics? Like, what about MDMA?
When you're talking about psychotropics, you're really talking about psychedelics. None of that stuff has ever been studied enough. MDMA is bad stuff. If you get a bad batch, it's really brain damaging. And it's also a felony to have, possess, sale, etc. MDA is nasty stuff. Again, it's where people get their ideas. They don't get, especially drug abusers, they get their notion from some pimply faced kid next to him who turns and says, "Here, this is great, try some." And that's all the endorsement that they need. Then you ask them to take a medication for ADHD and they don't want to put that poison in their body. It's everything I can do to keep them getting up and holding on the neck. But that's another story.
No, but it'll make a good social media post.
Yeah, that'll go viral for sure.
All right, we've got a couple of these other off the beaten path kind of questions. Do vagal exercises help with RSD?
I do not know.
Okay, unknown.
Unknown.
Does the
None of my
asker,
patients have said anything.
yeah, does the asker, yeah, they're not likely to talk about RSD. They're certainly not talking. Does the asker have experience with that?
I don't know.
Okay.
I don't know. Maybe they do. We'll see what pops up. Oh, and then we've got a vagal, not vaginal. Okay. Yes, vagal, not vaginal.
Oh, sorry. Oh, I mixed it up with Kegels.
It's dark out.
Dyslexia.
These aren't so good anymore.
It's been a long
on that
day,
one.
isn't it?
That's another good social media post.
About those Dodgers, right? Okay. And then there's it's just very cute. Love that. Didn't realize wacky was a clinical term. Excellent. What if there's so if there's a comorbidity of more than one disorder, can RSD be dealt with first before trauma, OCD, or general anxiety?
When a clinician is talking with somebody, they're going to come in and they're going to tell them about, sometimes there are multiple problems, but generally most patients will have one thing that brought them in. More than all the others put together, it was this one thing that brought them in the door. If I don't treat that first, that person very rightfully feels like I'm not listening to them. So yeah, it can be treated first. The order doesn't matter. What matters is that the patient knows that the doctor's been listening to them, working with them, is flexible, and wants to see them lead a happy life.
And your doc's in the right. You picked the right doctor when
Well,
their priority is that it go better for you. Yes, and we did get some feedback. Yes, that person has some familiarity.
okay, good.
This is a very early question, so I hope this person is still in the room. Guanfacine has resulted in jittery feelings in 2 folks who've added it to their stimulants. Emotional reactivity wasn't improved. What else is there besides guanfacine? Let's hope I pronounced it right. And the other one, I can't remember its name.
Clonidine.
Thank you.
It's a class of medications that are very troublesome to use. The monoamine oxidase inhibitor drugs. If you went to the pharmacy and you picked up a cold sinus or hay fever medication box and flipped it over, there'll be a sentence there about don't take this medication if you've had an MAOI in the last 2 weeks. These drugs interact with practically every other psychiatric medication. So you'd have to stop all of those. But all of those warnings said, the monoamine oxidase inhibitor drugs are the very best drugs that we've ever had for depression, for anxiety, or for rejection sensitivity dysphoria. They work great, but it really takes a responsible patient and a doctor as old as I am, because they don't teach about MAOIs anymore.
Mm.
We used to have 6, we now only have 2.
Yeah.
They aren't being used anymore.